Education is the most powerful weapon which you can use to change the world. As quoted by Bodhisattva Dr. Babasaheb Ambedkar, he himself proved this quote by changing the life of Bahujan and the citizens of this nation. Now we are starting our first session, that is scientific session. We organize scientific session to update and refresh our knowledge.
Dr. Shankar Khobragade, everyone knows him. He is past president of, he is a renowned diabetes consultant, senior consultant physician, diabetologist, cardiologist. He was president of most of the prestigious institute, Cardiology Society, Diabetic Society of India, API, AMF, and BAHO also. He is a knowledgeable academician and a brilliant physician. Apart from this, he has so many social activities and done so many other degrees. So with this brief introduction, I request him to please go ahead.
This is a case of right upper extremity weakness called as a silent killer. How a simple thing can kill you, so the story is very interesting. I had already presented this case during the installation of Academy of Medical Sciences. So he is Mr. Surjit Kaur, 31 years, unmarried, obese, distressed gentleman. He was brought by his relative on 16th of June 2023 to orthosurgeon Dr. Akhilesh Khobragade for evaluation of the right upper extremity weakness since last 3 months. After he had an accidental fall from his motorcycle 3 months ago while he was moving with his friend. So cause and effect, it is difficult and different sometimes. What was the reason for coming to Nagpur? He has a blunt trauma to the right upper arm, dislocation of the wrist bones, severe pain experience. There was no fracture. He took painkillers and crepe bandage applied. Physiotherapists treated him, but there was no relief. He noticed weakness in the upper extremity, tingling and numbness. Inability to hold the objects in the hands, small objects used to fall from his grip. Other complaints, breathlessness after walking some distance, 3 months, sweating excessively, neck pain, progressive to right upper limb, tingling sensation on presentation and mild weakness in the right upper limb. He took Ayurvedic trial for these complaints, but there was no relief. There was no history of fever, joint pain, TB, weight loss, anorexia or hepatitis. No cough, no GIT disturbances. There is a history of COVID-19 positive, but it was not that much severe and he was not admitted in any hospital. He recovered at home at that time. He was a non-smoker, non-alcoholic. Family history, father died because of unknown reason. Mother is a type 2 diabetes. She is on OHA. He is just engaged and dreaming for the marriage. Past history is hypertensive, 6 months on cilnidipine 10 mg. There was no history of asthma, ISD. But he was a case of hypothyroidism since 1 year and 100 microgram L-toxin he was taking. Examination findings, very fat young man, not comfortable in OPD. He was sweating. It was a month of June. Everybody used to sweat. No icterus, no clubbing, no lymphadenopathy and no signs of congestive cardiac failure. Weight was 110 kg. BMI 35, respiratory rate 28 per minute. SpO2 was 97%. And this examination, slight paraspinal spasm was noted. Patient was sweating. While noting the history, patient also elaborates that he does not sweat on the right side of his face. Patient was asked to open his eyes and could not do so. And this was the power on the right side. Shoulder 4/5, elbow 3/5, wrist 3/5, pinch, weakness, grip, weak. Left side was 5/5, normal. So he is a conscious, alert, distress, pulse 100 per minute, tachycardia. I would like to welcome Dr. Ravi Wagmare. Yeah. He has a hyperhidrosis on the right side, ptosis and ophthalmos. So simple clinical diagnosis of the Horner syndrome was made by the orthopedic surgeon. and he started investigating and referred to me. So manifestations of the Horner syndrome: ptosis, meiosis, anhidrosis, and ophthalmos. And systemic examination: respiratory system normal, CVS normal, per abdomen normal, CNS normal, higher function normal, weakness on the right upper extremity noted, lower limbs normal, plantars were normal. Now hemoglobin 13%, TLC, DLC normal, platelets 3,50,000. Biochemistry: hemoglobin A1C was 8.5. He was detected as a diabetic in the hospital. Blood sugar fasting 180, postprandial 235, total cholesterol 205, triglycerides were high, which having dyslipidemia, HDL 36 and LDL 110, blood urea 36, creatinine 1.4, microalbumin traces, urine sugar was positive, thyroid TSH 14, HIV negative, hepatitis B negative, and Montauk's test was also negative. This is ECG suggestive of sinus tachycardia. 2D echo for evaluation of the heart disease, whether he is some heart disease, 60% ejection fraction, no valvular heart disease, left ventricular hypertrophy. And what was his provisional diagnosis now? Can anybody suspect? History of fall, right upper limb, Manasvi? Okay. Yes? Pardon, please? Post-traumatic CRP. Okay. Any more guesses? Okay. Provisional diagnosis: obesity, hypothyroidism, hypertension, diabetes, dyslipidemia, Horner syndrome, and right upper extremity weakness. So this was the OPD diagnosis. What are the differentials at this stage? Like our vascular, inflammatory, neoplastic, usual chart, how you investigate the patient: degenerative, idiopathic, congenital, autoimmune, traumatic. So T, at least he gives history of trauma, endocrine, environmental. Differential diagnosis at this stage, like cervical radiculopathy, entrapment neuropathy, thoracic outlet syndrome, post-viral syndrome, brachial plexopathy, Parsonage-Turner syndrome, shoulder rotator tendinopathy, subacromial bursitis, adhesive capsulitis, glenohumeral impingement, and calcific tendonitis. These are the differential diagnoses when the patient present with the Horner syndrome. Radiological investigation like cervical spine was advised, it was normal, and this was a MRI done after that. MRI, it was a very surprise MRI, and he has a large, well-defined, lobulated soft tissue lesion at the apical region of the right lung, very big, like 13 centimeter. Subtle marrow edema noted in the posterior end of the first right rib, post-contrast enhancement, and lesion measures approximately 13 by 14 by 18 centimeter in the size. It was a silent, and there was no complaints of cough, hemoptysis, or any respiratory symptoms. He has a brachial plexopathy only. So cervical dorsal spine was advised. Picture inside was very striking, and this was a large mass in the right hemothorax. Patient was not anything, and we are also very surprised how he has tolerated. These are the various views of this. So MRI, large well-defined lobulated soft tissue mass, and now what to do? Pleural tumor was found, post-contrast, and this was the lesion. Now he was referred to cancer hospital, thinking that it is a malignant tumor or a benign tumor. What should be further investigated? So patient was referred to National Cancer Institute also, and it showed large solid lesion involving right thoracic cavity extending in the mediastinum and the right supraclavicle neck region. So it was severely compressing right subclavian artery also, inferior jugular vein with the thrombosis, and the right coronary carotid. So they have done CT guided core biopsy from the right thoracic mass, and the report came as a intermediate grade spindle cell sarcoma. So this was the diagnosis. Microscopically, classic mesotheliomas shows both epithelial and sarcomatoid pattern, and this consistent of glands, tubules, solid sheets of tumor cells, abundant eosinophilic cytoplasm, and they have diagnosed it as a sarcomatoid tumors. And now what is the follow-up? Diagnosis is done, now what to do? So after 1 month, in case of this intermediate grade spindle cell sarcoma of the right thoracic cavity for evaluation, he was again evaluated, and at that time he showed evidence of the large solid cystic lesions noted involving the right thoracic cavity extending in the mediastinum, right supraclavicular neck region with the vascular bony involvement and other extent. Severe metastasis after 1 month. It was a very fast growing. Multiple varying size, heterogeneously soft tissue density nodules noted, subpleural region of the right lung and the left lung parenchyma also, both the sides. So it has consistency with the neoplastic etiology. Largest measuring these nodules were in the metastatic region in the right middle lobe, and these are the various reports. And he has various lymphadenopathy, cervical, axillary, multiple lymph nodes. So final diagnosis at this stage is a pleural malignant mesothelioma, intermediate grade spindle cell sarcoma, clinically Claude-Bernard-Horner syndrome due to malignant pleural mesothelioma. So what happened next? So patient was referred to this hospital and they have investigated, but surgery was also advised. I had referred the patient to Kingsway, to thoracic surgeon. She was ready to operate, Dr. Shobha Gandhi, and she was very much interested in this patient, what happened. But patient would-be father-in-law, he was having faith in the Ayurvedic medicine. He took his would-be son-in-law to village and started him on Ayurvedic treatment. Patient refused surgery, chemotherapy. So the bird who refused to fly, what will happen to that bird? Went back to his native place. He took Ayurvedic treatment and developed metastasis in the lung, severe pulmonary and everything, even the brain also. And he had a fall in the bathroom, unfortunate patient. He developed left-sided hemiplegia and bedridden for 1 week and unfortunately died in the sleep. So discussion, why it is called mesothelioma? Because it is derived from the Greek word mesios means middle and oma means tumor. It is a rare cancer that originates from the deregulated cellular proliferation of the mesoderm tissue lining the chest cavity, heart, lung, abdominal cavity and the intra-abdominal organs. Up to these 7 cases of this Claude-Bernard-Horner syndrome due to malignant pleural mesothelioma are described, and all the patients were middle-aged farmers and lived in the rural part of the central Anatolia because of the asbestosis. So this is the differential between malignant mesothelioma and adenocarcinoma. Mesothelioma diagnosis was extremely controversial and required autopsy at that time. Today, the diagnosis is still problematic. 15% of the cases cannot be differentiated from the adenocarcinoma. So there are some facts about the mesothelioma. Around 3,000 people are diagnosed with mesothelioma each year. Approximately 75% of the mesothelioma victims are male. Symptoms can take up to 10 to 15 years after exposure to appear. But in this case, I don't know how many months he has developed to this because he was asymptomatic. The average life expectancy for the mesothelioma patients with the treatment is 12 to 21 months. But he has developed this very fast and died within 2 months. Pleural mesothelioma is the most common type, making up more than 80% of the diagnosis. The only known cause of mesothelioma is asbestosis exposure. But as he was from Balaghat and near the mines area and I don't know exactly, and he has not given any history. Father died, I don't know because of this cause. So this is a form of cancer that most frequently arises from the cells lining, and the type of the mesothelioma are pleural, peritoneal and pericardial also. So these are the common symptoms, but which was not there in this patient, like cough or effusion or weight loss. Rather, he was very obese, 110 kg weight. 50% of the patient do not have any history of the exposure to asbestos, and these are the literature. I will not go into detail. And these are the types like epithelial, mesenchymal, mixed type, and incidence I already did. And this is the majority of the asbestos patient, like fibers or other amphi or serpentine. Occupational was not there. Malignant, diffuse mesothelioma. This is the pathogenicity that malignant mesothelioma is thought to be originate from the parietal pleura. This is the clinical presentation. 7% of the time, multinodular pleural tumor found 0.5% of the time an emphysema, and 0.5% of the time spontaneous pneumothorax, which were not there in this patient. X-rays like this. Serum markers can be definitely helpful, like soluble form of protein mesothelin, if you suspect. Then PET, this also is important, which was not done in this patient. Thoracoscopy was planned, but patient has refused. Now, video-assisted surgery also, thoracoscopic surgery is also important in this. And it is a grape-like appearance on this VATS. So it looks like this if you do it. 98% of the sensitive in establishing the diagnosis. Mortality is 1:8,000. Complications are minimal. And these are the staging. Mortality occurs due to local extension, respiratory failure, and various types of arrhythmias or heart failure. Prognostics factors like thrombocytosis, leukocytosis, low hemoglobin. Good prognosis if epithelial histology, age less than 65, but this patient was unmarried 31 years. Treatment, these are the various modalities like surgery, radiation, chemotherapy, immunotherapy, and the gene therapy. But patient should be willing for this. But does not surgery improve survival? It is a very complicated surgery, and but there are surgeons at present, they are ready to take the risk, and that surgeon was very much interested in doing the surgery. New approaches like emerging mesothelioma treatments are also there, like anti-angiogenesis treatment is also available, and immunotherapy, biological therapy, and BRMS may be used. So immunotherapy is, gene therapy is also available, and this photodynamic therapy is also available. So conclusion, in these patients, mesothelioma kills slowly and effectively, but this patient, this mesothelioma, he has killed very fast, but that tumor might have been very asymptomatic, and X-ray was not done even before also. So to find early stage disease, remember the risk factors like age between 55 and 65, previous occupational exposure to asbestos, which patient has not given the history, proliferation and all that. So diagnosis is the best established by these VATs. This is the conclusion. And treatment, it is currently the clinician choice, multimodal approach, including the radical surgery, limited role for the limited surgery, palliative, relief of the symptoms. So virotherapy is also available, and these are the references which I have taken from the literature.
Dr. Neha Shinde has done MD Pediatrics from NKP Salve Institute of Medical Sciences, and currently she is working as senior resident in the Department of Pediatrics.
So a 17-year-old male, first issue of non-consanguineous marriage, presented with a history of large joint pains of both upper and lower limbs since 2 months, fever on and off since 2 months, generalized weakness and easy fatigability since 15 days. The joint pain was non-migratory in nature, there was swelling, and there was a restriction of movements. Fever was low to moderate grade in past, and since last 8 days, it was high grade. On clinical examination, the patient was sick looking, severe pallor was present, petechial rash over the lower limbs was present, ecchymosis over right cubital fossa at the prick site, forehead swelling was present, as it is showing in the image, and bilateral insignificant inguinal lymph nodes were there. On per abdomen examination, it was soft, liver was 2 centimeter palpable, firm in consistency, and spleen was 1 centimeter palpable, and it was also firm in consistency. On locomotor examination, these various joints were involved. So the right knee, right elbow, and right shoulder were involved, with maximum swelling were present at the right knee and right shoulder. And there was also local rising of temperature at right knee and right shoulder, and also effusion was present. And maximum, there was a restriction of movement at the right knee, and right shoulder joints. So on investigations, when he presented to us, there was a severe pallor. So HB was decreased at 3.7, PLC count was 3000, ANC count was 1950, and there was a thrombocytopenia, and CRP was raised. And his other investigations were done. So there was increased in ferritin levels, which was around 3,480. ESR was raised 32. Triglycerides was 261. And so on the basis of symptoms and history, there were diagnosis towards the any rheumatic conditions. So other panels were also done. So ANA was negative, HLA-B27 was negative, and RA factor was negative. His X-rays were done, but in X-rays they were normal. There was no any destructive process. So differential diagnosis were kept considering pancytopenia with arthritis. Initial differential diagnosis were hematological malignancy, probably acute leukemia, and connective tissue disorder, probably systemic onset juvenile idiopathic arthritis with macrophage activation syndrome. So the bone marrow was planned. A bone marrow biopsy examination aspiration was done, which was suggestive of bilineage dysplasia. Bone marrow biopsy was suggestive of extensive bone marrow necrosis with scattered viable myeloid precursors. So in view of primary macrophage activation syndrome, after taking rheumatologist opinion, the patient was started on corticosteroid therapy, and also intermittently he received PRC transfusions and fresh frozen plasma transfusions also. Following the corticosteroid therapy, there was improvement in his symptoms. Fever was subsided, and intensity of bone pain and joint pains gradually reduced over the period of next 1 week. As the serial CBCs and inflammatory markers were not showing improvement, again cyclosporin was started and PET scan was done to rule out any metastasis or to rule out any suspicion of malignancy. So his CBC trends were done. So after starting corticosteroid therapy and cyclosporin, there was an improvement. But again, after 15 days, again he developed fever, joint pain, and pancytopenia. So patient again developed fever, pain, and pancytopenia. Repeat bone marrow aspiration and biopsy was done, and this time it was inconclusive, and PET scan was done. So PET scan study shows extensive lytic sclerotic skeletal lesions with marrow involvement involving throughout the axial and appendicular skeletal system, with few of which showed increased metabolism and metabolically active bilateral pelvic lymph nodes. So there was the thing where we again proceed for the further, and we proceed with the internal iliac lymph node biopsy, and that was the after biopsy. It was the given as a metastatic poorly differentiated signet ring cell adenocarcinoma, probably from the GI tract origin. So the final diagnosis was metastatic signet ring cell adenocarcinoma, probably from the gastrointestinal tract. So I would like to highlight some things about signet ring cell carcinoma. It is quite rare in the pediatric population, and the cases are also less reported. But it is a signet ring cell carcinoma. It is a form of adenocarcinoma which arises from the glandular cells, and it leads to the mucin production. And the most common signet ring cell carcinoma, it arises from the stomach. Approximately 90% they have origin from the stomach, and the rest are from the other organs also, like colorectal carcinoma, pancreas carcinoma, bowel carcinoma also noted. There is one rare report in pediatric patient where the signet ring cell carcinoma presents as a intestinal obstruction, and after getting operated, it was diagnosed as a signet ring cell carcinoma. So it has the prognosis has very poor, because it has a highly malignant metastasis potential.
All dear seniors, teachers, my colleagues, families, we are having in scientific, we thought of starting from today itself, as we are celebrating the annual day of BAHO. So why not to have an oration on the name of the stalwart, well known nationally and internationally. So the oration is on the name of our beloved late Dr. Krishna Kamble sir. I first request the family members of Krishna Kamble sir, Shweta and Amit Praveen, to kindly come forward. He always used to say that Bhavatu Sabba Mangalam, सर्वांचं मंगल हो. त्यांनी सर्वांचं मंगल केलेलं आहे. When I was an undergraduate, I saw that he was the only person in entire medical college who used to come forward without any hesitation, without knowing his position, without knowing the person from where the patients are coming, and he was helping everyone out of the way he was going for everyone. He had organized many international conferences. His academic work experience was a least long. Working in radiation oncology since 1978 in GMCH Nagpur in various capacities like the professor, head in teaching radiation oncology to postgraduate students, and also organized the regional workshops. We can never forget his contribution to the society, to his people, not only his people, to the entire global. Whoever used to come and ask for the help, he was the first person to be there in the list. And everyone used to think for Dr. Krishna Kamble sir. So this oration is dedicated to Krishna Kamble sir. And for this oration, we have a very renowned stalwart of internationally acclaimed Dr. Shriram V. Kulkarni sir. He had come along from all the distance, Mumbai. He told me that he had only this Sunday available with him. He had come on his own. He is a very great friend of Dr. Satish Dev Pujari sir, and he stayed with him also that yesterday night. We are very much grateful to Satish Dev Pujari sir. Your presence is recognized, and definitely we hand over for the artificial intelligence and digital technology in medicine to Dr. S.V. Kulkarni sir.
This is very important topic because we have got digital technology and artificial intelligence. It's a day-to-day life. We are coming across with all these things, and Dr. Kulkarni will tell you about the artificial intelligence in health service, health department.
A question is asked, is AI and digital medical technology is too much unexpected? Is it a tsunami? We have all suffered for last 2.5 days. Millions of people lost their flights, they have rescheduled their work just because of one incident. But are we doing something over as far as AI is concerned? Friends, the answer is no. Because AI is not for today. AI is as old as me. It is a long story of 1956 to 2024. It is a story of lot of expectations, lot of errors, lot of learnings. And when this gentleman, John McCarthy, and before that, Alan Turing is a legacy by himself. You must read his autobiography. You will be mesmerized. What they wanted some machine who is going to think like human and help in the work. And don't consider AI as an artificial intelligence. It is an augmented intelligence. It is an assistive intelligence. It is going to make yourself very much proficient in your profession if you use it properly. One question which is always asked at the end of the oration is AI going to replace the doctors? The answer is no. But AI is going to, the doctors who don't use AI will be replaced by doctors who are going to use AI. That is for sure. You may recall something which happened so many years back, 27 years back. 2 times world champion, Garry Kasparov, was defeated by an inanimate cheese called as a deep blue. And then after n number of things have happened in this field, and we are all amongst the sea of artificial intelligence. So what are the advantages? Accuracy, big volume of data is handled. It is consistent, it saves time, money, efforts. The trouble and torture of travel, you imagine so many webinars Dr. Devpujari, Shankar must have given during COVID times to educate people. But friends, please remember, it increases your serum level of confidence, concentration, competence, and most important, enthusiasm. It makes you acceptable, adaptable, humble, and a new learner, mainly from your juniors, and my greatest teachers are my grandchildren. त्यांचा ॲटिट्यूड असते काय कसला आजोबा याला एवढं साधी पण गोष्ट कळत नाही. You pamper them, they will teach you quite a lot. Just to tell some more positive benefits, only the headline: availability 24/7, no leave, accuracy at the best, data analysis and insights. It enhances efficiency. Are you future ready? One question. Where you have learned your WhatsApp? Where you have learned your mobile phone operation? Nowhere. There is nothing like a WhatsApp training school. But if you have to be future ready, you have to be part of this. It is a personalization. You will get a cancer treatment without losing a single hair. That is the power of personalized and precision medicine. And there is a huge amount of work going on safety and risk reduction. Okay, you keep AI on one side. How we learn? How we learn? You have data. That data is consolidated into information. That goes to knowledge, and that goes to wisdom. What you are writing on the prescription of a 11 condition patient is your wisdom. Otherwise, everything is available on Google. It is acceptable and adoptable. One more different way of looking towards those things, just ask a question to yourself. What we are, what we have done, and what we need to do. We have conquered some diseases. We have discovered some new diseases. We have prolonged life expectancy. There are people 95, 98 years walking without a stick on the road. Reduce suffering, improve sense of well-being आणि quality of life. या दोनच गोष्टीत प्रत्येक पेशंटला विचारायचं, what is your sense of well-being, what is your quality of life, scale from 0 to 10. And your patients will be happy if you start using this technology. But at the same time, we also have limitations. We are looking for a ray of hope, beacon, magic wand of hope, but not a panacea. It will not answer all your questions. One unusual term I am going to introduce to you. That is called as the medical literature doubling time. Harrison first edition, 1950. 2022, 21st edition. In 1950, it was expected that it will take 50 years to double the medical time, knowledge time. In 2002, it is 73 days. Now it must be less than 10 days. And see what is going to happen. And the biggest thing is the challenges are there. The costs are rising. There is a prolonged drug vaccine delivery, drug trials. There is an explosion of healthcare data. There is a dynamic, rapid and continuous update of this knowledge. And unfortunately, it leads to burnout. The serum frustration levels of all the medicos and students and paramedicals are increasing. People are getting upset fast. Number of suicides are getting more. If you give a touch of technology to this, I'm sure you are going to be much more benefited. We used to say, "Dunya meri mutti mein." So if one smartphone might have replaced your not 125, but 50 equipments. And a time may come, the number will increase. So let us be very practical. We will start from simple to complex. Let us start our journey from our OPD. How you can use digitalization. Use digital marketing for you known. Initial data, demographics, repeated things. Fixed parameters, variable parameters, health record. In any form or other, use an electronic health record. Otherwise, make an Excel sheet. Excel is excellent. There are a lot of POCT equipments, point of care equipments. After the oration, if you are interested, I can show you 5 of them. And the communications and referrals also be very good in the world of medical legal era, because whatever you are doing, it should be properly documented. This is the way to smart clinic. And if you have got a patient, what all you can monitor? You can monitor so many things. There is a full gang of a cricket team of body sensors you can manage. And after some time, you are going to get a gadget like this that over only one dabba, and then you decide what you want. Whether you want to temperature, pulse, respiration, alarm, ECG, FHS, everything can be done. All of us are aware of this instrument, the gun which is to point temperature. But if you fix this instrument on the entry of your clinic, any person who is walking through, if he has got more than 100 fever, it will give a beep. Why on wall? It can fit on a mobile also. If you want to see, it is there with me. Simple. SpO2 pulse rate we are measuring, but I will give you a pulse oximeter which even measures temperature. One measures respiratory rate and another called as a perfusion index. You are all managing dengue patients. Perfusion index is one condition which will tell you whether the patient is going down the hill or not. Forget about this kind of weighing machines. They are very smart weighing machines. This weighing machine, this gives the temperature also, and this gives the body composition analysis. Body fluid for a CHF patient, for a chronic renal failure patient, for a dialysis patient. What is your muscle mass? What is your body fat? Lot many things can be done. Take measurements, not only height, weight, waist, neck, arm, they are important. In this, arm and calf are your muscles. The rest of them is fat. Even there is a study on height to wrist ratio, which is much better than body mass index. All these instruments can be very smart. They don't need any wires, cables. They will go directly to your EHR. There are a very good amount of tapes which are available. They are even 0.00 level. Means if my neck circumference is 42.67 centimeters, it will show you as a 42.67 centimeters. And these are the smart height scales. You put the height scale, person stands below it, and you get the height on the digital things. When we are teaching our patients, digital technology helps prepare a message like this. Send to all your patients who are doing their monitoring of blood pressure. The biggest mess in blood pressure apparatus is the tube and the bulb. So you get BP apparatuses like this. There are BP apparatuses even which talk to you. They tell the things. And this type of BP apparatuses you can keep on the arm. You can move around. You can do your exercise BP apparatus or ABPM. This is a stethoscope which is made in India. I can hear my patient's heart sound sitting in here where my assistants are keeping the stethoscope on my patient's chest. It costs hardly 10,000 rupees. ASOM, very common in pediatric age group. Children are scared of it. So just you can get everything on mobile phone. This is a Wells Allyn examiner system. You get a fundoscopic image. And this is a digital portable fundus camera. It acts like a detective in your body. I'm going to tell you which are the other diseases which can be diagnosed only with this. From eye, you come to ECG. This is a point of care ECG machine. But don't forget this. This is a 17,000 rupees device. If somebody crashes here, without jelly, without tube, I can take a 6-lead ECG within 15 seconds. And that is possible. There are a lot many other 2-in-1 instruments. These are the combo equipments like a BP and ECG which is available from Omron. You call them Omron Academy. They will do a good program on this. These are the glucometers. These glucometers, they fit on a mobile phone. And immediately the sugar result goes to the concerned doctor or the family members. There are a lot many things like this. You can have connected machines like CGM. But what is the biggest problem in diabetes management is the finger prick, the pain. And Dr. Dev Pujari has seen yesterday the invention. It creates a small vacuum and it floods it so fast the patient doesn't feel pain. In diabetes management, you can have a CGMS like this, 14 days. These are the different kind of sensors, small things like this, and you can, if there are good electronic and engineering colleges here, you prepare a project that constructs something like a hypoband, which detects cold sweat. Hypoglycemia detector is a boon for a patient. The other clinical condition where patient will have cold sweat is AMI and GI bleeding. These are the K watches. These are the glucose K vitality. It is a French thing. This is from Israel. It is a non-invasive glucometer. This is a smart insulin pen. It is connected to the glucometer and it tells you approximate amount of insulin which is required for the patient. We measure everything, we don't measure muscles. So how you measure muscles? This is a hand grip analyzer and it is an objective measurement of. There are advanced 15 parameter things which are available. This is again for Israel. We are not using cameras very properly. But these are the cameras which are dental cameras for the inside of the mouth, early detection of oral cancer. Skin is supposed to be the largest organ of the body, and you can detect so many skin things with a simple dermatoscope which magnifies the thing 300 times. So skin is a mirror of body and sense of well-being. You can diagnose acanthosis, you can diagnose a fungal infection. What you wear on your wrist, it is increasing and it is growing faster. So with a wristwatch or with a sensor attached to your mobile, you can monitor so many things, and it will promote fitness. How it will promote fitness? It will tell you how many kilometers you have walked, how many steps you have walked, how many calories you have consumed. So these are the things which keeps the patient engaged. The patient engagement in today's management is very essential. Here it will tell you and also how much he has walked, and there are many smart watches called as a Noga smart watch. The watches are now replaced with rings now. This is an ultra-human ring which monitors pulse, oxygen as well as sleep. It can diagnose obstructive sleep apnea. There is an Indian counterpart of this which can be connected with a ECG and glucometer also. Those who are physiotherapists here, there is a concept called as a augmented reality, virtual reality, mixed reality and immersive reality. The person is somewhere in AIMS, but sitting here in front of the TV, wearing a head mount set, you can do the same exercise, whatever you want to do. These are the advantages. For the neurologist, sir, forget the word plagia. There is not going to be plagia. Not mono, not para, not quadriplegia. There is something called as exoskeleton, which is going to help the people. There are many new things are coming. Robotics is one. In that there can be care bots, robots as helpers and robots as assistant surgeons. Please develop rapport with the patient with technology and insist for something like a patient's identity card, a vaccination chart. Ask him to be very productive for annual medical checkups. The stories are unending. There are going to be equipments like this. This is called as a skin patch. In that skin patch, sodium, potassium, chlorides, ammonia, everything will be managed. All encephalopathy patients will be watching with this skin patch. This is a Google Lens, in which there is a small lens and I don't need a screen. Somebody can see the whole screen in the air. So these are new things, but they are practical, they are on the horizon. This is not a vest, this is a halter. This is another skin patch. This is not a pendant. This is a fall detector. If a geriatric person falls, it is something which is going to be detected immediately. So friends, in your practice, be innovative, funny, humane. This is one new instrument which I saw recently, that is to improve your soleus muscle and prevention of deep vein thrombosis. You should be very jocular, we should be very humane, funny, practical. Don't be very serious. With the help of technology, if you have got a good big TV and there is a Cartoon Network is going on, not the children, but elders also enjoy it that much. So now I shift to my second part of presentation, and that is about artificial intelligence. So is AI in and around us? It is. Your mobile, the moment I type Shankar, the name comes as Shankar, Khobragade, Nagpur. So that is the predictive typing what here. It is all around us. It is ubiquitous, universal. It is a true milestone. We have used abacus, calculator, computer, connected instrument. Now we are using ChatGPT. And that is called as a generative AI, which has got an unimaginable outcome. I am going to show you certain examples. So as to create awareness among the physicians, I have written one editorial also in JAPI, and that was really appreciated internationally. People were thinking that Indians are not using technology to that extent. But this was an eye-opener for that. So what we are doing? We are using blockchains, telemedicine, 3D printing, quantum computing. When it comes, it is going to be absolutely fantastic. So this is the spectrum of artificial intelligence or digital technology. On one side, you have got simple calculators, EGFR, ACVD score. Then these are the risk scores. These are predictive models. You fill in all the data and it will tell you so many chances of developing a ACVD. There is a targeted neural nets. Then ChatGPT, which is part of the generative AI. Friends, what happens to any technology when it comes in the world? There is a peak of inflated expectation. There is a trough of disillusionment. Pagers kutte sanga mala to. Where are the pagers? Where are these dabba TVs? They are all gone. Then there is a slope of enlightenment. There is a plateau of productivity. But if you look at this particular place, generative AI is still at the top. Generative AI is still the king. Why there is increasing focus of research? See the number of publications, see the number of money which is involved. These are the annual things, Global AI Market, Statistician, Gartner, and Servian Global Solution. They predict how the world is going to go in economies in the next 5 years. Everybody has said that it is only AI. Now suppose, imagine this room. We are all 1,000 human beings and there is only one tiger. How we are going to identify it? With the help of computer vision, the AI will identify in milliseconds. And we have to search for everybody's face that he or she is not a tiger. This is also an example of whether it's a horse or a car. You show a picture whether it's a horse or a car. Or there is an accident in Surendranagar and the car is going towards Bardi. With that camera, it can say that the black color Tesla, which can be stopped there, it is all because of the image analysis. What I am doing in my medical college, I am punching my finger, my face is recognized and the National Medical Council knows. But how I pick up this in my day-to-day practice? We are all private practitioners. So facial recognition is a very great boon to prevent violence. The camera which picks up the emotions of the patient, and this is an Indian study. I'm not showing somewhere anywhere else, but facial recognition to real-time learner, and it has been put on with the animal studies, and it can detect violence. It can detect the possessions of the patient sitting in your, if you are sitting with a cricket bat and he is sitting with a hockey stick in my consulting room, तुम्ही का माझ्याशी खेळायला आलेला नाहीये, तुम्ही माझं केबिन फोडायलाच आलेला आहे. So it detects some abnormal things. Some of they detect the guns in the American setup. So we must have heard so many times, इसके लिए ये दबाओ, उसके लिए वो दबाओ. That is all chatbots. So what that chatbot can help me? A middle-aged man, non-diabetic with chest pain. It will ask you 3 or 4 questions and it will give you where to go, whether you want to go to emergency or whether you go to casualty. You can explain the symptoms of hypoglycemia to a patient. Hypoglycemia is very dangerous certain times. People stop cooperating to the diabetologist. But if they know that these are the symptoms, then they will definitely cooperate. Any forensic medicine person, there are virtual autopsies now. No direct autopsies. For the pathologist, this is an AI-enabled digital pathology and microbiology. What pathology can tell? Not only hematoxylin eosinophil, it will tell you driver mutations, malignant or benign, site of origin, structured genomic changes, response to therapy, prognosis. Our hero of today's oration, Dr. Kamble, must have given so many chemotherapies to people where the site is not known. Site of origin, we get metastasis and we don't know what is the site. Suppose there is something absolutely funny. This is a patient of an endoscopy. He had this image. It can make a rare diagnosis. This is called as an augmented endoscopy. It is asking a question, explain the object appearing in the left side of the screen. I'm sure nobody must have heard this disease also. The object resembles an artery wall situated close proximity to the duodenum. The given size location, it is most likely to be aorta and it is going to be aortoduodenal fistula. Very, very rare condition, but if you diagnose, if you treat, the patient's life is saved. Eye is the gateway of the diseases. You can diagnose everything. These slides I am going to give to Dr. Shankar. You can download. There are references. You can diagnose diabetes. You can diagnose kidney, liver, heart calcium score, Alzheimer, hyperlipidemia, and even Parkinson's from fundus. Any references? Yes, these are the references, and it can tell you 5 years risk prediction, 70% accuracy, CHA prediction, not very high tech. Your smartphone camera also is sufficient. You don't need anything very hi-fi. Do not forget the windows to peep into the inside of body called as oculomics. Systemic disorders. And this is one abnormality for the cardiovascular risk prediction. This was the model with fundoscopy, angiographic correlation, patient's outcome. All the things have stood absolutely perfect. A digital ECG is something much better. It will not only diagnose the cardiac condition, but age and sex, ejection fraction, difficult diagnosis, anemia, hyperthyroidism, kidney disease, peripartum cardiomyopathy. I must have missed so many. All females coming after delivery, 6 months, 7 months, 8 months, breathless with cardiomegaly. Thank to this man, not to this man, but his wife, who allowed him to take the first X-ray of the world. And that is his wife and the first ring which Ranjan has showed. And now the X-ray department is on a small table. It is on a small bag. It is on your mobile. But can you diagnose diabetes from a chest X-ray? Yes. Lakhs of people have been screened and you can diagnose diabetes. Can you diagnose a small nodule, whether it is benign or whether it is malignant, with confidence? There are many LLM, large language models, which help it. This is improved nodal detection of chest radiographs in health screening program. COPD. There is a pulse PFT meter which can be attached to your mobile, and it tells you, depending upon what is the atmospheric SO2 and other conditions, it predicts an attack of your COPD or asthma. This can be done by every physician. You have got a patient with diabetes, correlate with the biochemical parameters and ask what is the risk of that person to develop. So friends, generative AI application is the future of technology in medicine, and it is in the healthcare industry, which is going to be everywhere. Medical imaging, drug discovery, personalized medicine, generating synthetic medical molecules, and risk prediction. Forget Google to search. ChatGPT, everybody should spend money to have a paid ChatGPT. And ChatGPT is a large language model which transfers learning with supervised and reinforcement. This is the difference between technology and human being. Technology learns without any reinforcement. As the data comes in the World Wide Web, technology learns by himself. Med-Palm 2, you must have heard. The USMLE examination passed by a computer. This is Med-Palm 2. The passing score was more than 60%, and in this expert doctor medical exam questions, 85%. New England Journal of Medicine, all the CPCs, they are solved by that. Please don't forget this some simple application called as Elicit. Elicit will help you to write a paper. At the same time, if you want to do some odd things, I want a picture of Mona Lisa, a yawning Mona Lisa near the real one. This is also possible by a program called as a Video Poet. I want Albert Einstein playing chess with Narendra Modi on Great Wall of China in Blue Jersey. Okay, can see everything later. Or I just change Narendra Modi from Sushil Kumar Shinde, because I am from Solapur, Tuldapur. I know him very well. He's a fantastic personality. You should call him as one of the guests now. You can see against the background of Paris. I have not done anything. I have just given a command and it has gone. You can integrate all these videos into one partner. Google AI Muse. It is a text-to-image generation. What I told them, I typed, I am skating over the rings of Saturn. This is me. These are my skates. This is Saturn, and these are the rings of Saturn. You can create any type of image. If you want fantastic PowerPoint presentations, Gamma. Gamma AI is one. It can help. There are many things which can help. Freed, Merlin AI. I'm just going to give the names because we have got constraint of time also. 12 feet. 12 feet is the name who get everything free. Playground AI, good for research. Gemini is one good thing. And if you want to debug somebody there, you can debug the code. These are the apps which are available. If you want to have analyzed, create some formulas. This is called as a formula dog. It is a very good application. But from when to learn all these things? You are the best guru to yourself. You know what you want. So there are dedicated journals on AI and digital technology. And they are not 1 or 2 years old. They are at 15, 20 years old. This was our monograph which we published in 2023. It was the first type of the book in the world. It was a digital technology in clinical medicine. This is a journal which has come. That is NEJM AI. If you are in all the medical schools, VC sir is there, so you can subscribe to this journal. It is very costly, and we should do more and more research work. We are all good clinicians. All of you must be seeing 100 patients a day. But where is the data? Where is the conclusion? Where is the analysis? Friends, it all depends upon you. How you are looking at the things, whether you are looking to a magnifying thing or whether you are looking for a peephole. Last few slides, there are going to be some challenges, concerns, compliances, consideration. The big one is ethics, safety, privacy, ownership. We need to integrate the curriculum. We should find the students' perception, which will help for skill development. But somebody asked me, is it going to kill creativity? Is it going to make us as an AI-enabled dumb? Are we going to be fooled by this? So this is a new qualification, AI-enabled dumb medical professor. It should not be there. All the students should be much more. So friends, in conclusion, AI holds a great promise for revolutionizing medical education, research and practice. It enhances learning experiences. It provides personalized education. It improves your clinical skills. It is important to address the challenges which are associated with implementation and whether to accept or not. Whether you say want to yes or no, it is going to be there. So health.edu.ai. So whatever is knocking at the door, open the door, accept it. And I am very happy to see somebody after 1978 from PGI Chandigarh. Dr. Chandrasekhar Mishram, we are very, very proud of you. And the way in which you have been doing your job to the central India and Nagpur. Actually, if I would have been in PGI, his and my teacher would have been same. So whatever is knocking, but it is not very costly. It is not complex. So do some Indian jugaad. This is a typical Indian jugaad. Whatever we can do. And AI and digital technology is like swimming, cycling, horse riding. तुम्ही सायकल वरनं पडला पाहिजे, पाण्यात बुडलं पाहिजे, घोड्याने तुम्हाला फेकून दिला पाहिजे. Then only you can enjoy it. You will see hospitals like this, AI-enabled hospitals, which will be the chain logo. So friends, make a switch from old, mundane, conventional to modern, best, efficient and enjoyable. Don't sit in Wright Brothers plane, sit in a AI 380. If the software is okay, you will get the flight in time. There are many more things. I can't explain everything in 20 minutes. It is a very, very big subject. If you want, this is my WhatsApp number. This is my email ID. I will send you this presentation. And please join Doctors AI community. Adopt, practice, preach digital technology and AI.
Thank you, Dr. Kulkarni. It was mesmerizing to watch the various developments as far as the artificial intelligence is concerned. Those who have those work equipments they have been produced, they were definitely intelligent, but I don't know if people using it how are intelligent they will be. It is customary not to ask questions in the oration, but yes, it is going to be help. Maybe it will be with some disadvantages. Whatever inventions come, there may be few disadvantages, but the advantages are many more, and therefore this is going to be developed in the future and will be helpful to the human beings.
He is such an nationally, internationally acclaimed stalwart, and this memento trophy is in association to both of us, but definitely we would like to felicitate Dr. Satish Devpujari sir with a shawl and bouquet. Thank you, sir. Because the name is only one here on the trophy. It is S.V. Kulkarni. So I like all the chairpersons to kindly do this favor.